And on behalf of South Calcutta Medical Association, I welcome all of you in this very important CME and cardiology update. First of all, Shubh Navavarsa to all of you. Shubh Navavarsa. And this is the CME is being organized to celebrate this Shubh Navavarsa. So we are going to start our program. Today is the chairperson of Dr. S.P. Ganguly. And Dr. Kundu. Kundu. I request Dr. Mamta Datto to present flower bouquet to our chairperson.
No. Nice.
We are lucky to have a very renowned cardiologist, Professor Suvro Banerjee. He is a senior interventional cardiologist in Apollo Multi-Specialty Hospital and adjunct professor. I request Dr. Banerjee to come on the dance please, and I request Dr. Chakravarti to present a flower bouquet.
उनके फ्लावर बुकेट है मिल
I will hand over back to chairperson to start the proceedings.
Good evening, everybody. So, as we all know, hypertension is very common in our clinical practice, and lots of drugs are there to treat hypertension. But even after that, we encounter resistant hypertension. Often, we are not able to control hypertension in a group of people. So, we need to know the treatment, and we need to know the latest discoveries in the field of hypertension, and that is probably renal denervation therapy. It is not very difficult, and the patient subset for renal denervation therapy is not very uncommon. And so today's topic is basically about the patient selection for renal denervation therapy, which is very important. And it is not a very difficult task, not a very difficult procedure, and not even very costly procedure also. So with these introductory words, I ask Professor Suvro Banerjee to start his lecture.
So thank you, Dr. Kundu. And good evening, everyone. I'm certainly privileged to be invited by South Kolkata Medical Association to this meeting and deliver this talk. So I'm going to talk on selection of patients for renal denervation therapy, often called RDN in short. Of course, I'll be talking about selection of patients, but first of all, I will say a few words about the importance of hypertension and where does renal denervation therapy fits in management of hypertension. Now, as you know, hypertension is a global health crisis. Worldwide, there is about 1.1 billion people with hypertension, and it's estimated that by 2025, 1.6 billion patients would be having hypertension. And it is the single largest contributor of death. And in the US health system, it's been estimated that if you can control hypertension, you'd be able to reduce the healthcare cost by about more than $18 billion. Now, what does the guideline say about the targets or the goals for hypertension? If you look at the latest guideline of the ESC, which was published in 2024, it says that your target should be, systolic blood pressure should be between 120 and 130. And that's a class 1 indication. That's if your blood pressure is controlled to less than 130, that's between 120 and 130, but the diastolic blood pressure is still above 80, you should make all efforts to reduce the diastolic blood pressure to less than 80, that's between 70 and 80. And the guidelines also say that in certain cases, you may relax the goal a bit. In other words, instead of the usual targets of systolic blood pressure between 120 and 130, you can relax it to about less than 140 systolic in patients, for example, who have orthostatic hypertension, which is symptomatic, or in elderly or frail who are more than 85 years, or patient who cannot tolerate a lower blood pressure between lower than 130. Now, so far as treatment and control of hypertension is concerned, you know that about 30% of patients with hypertension are not treated. And even those who are treated, about 35% are not controlled. So only 35% of patients with hypertension are treated and have their blood pressure controlled to targets. Now we know that hypertension is a preventable cause for heart attack, stroke and death. And if you can reduce the office blood pressure by 10 millimeter of mercury, then you are going to achieve 20% reduction of major cardiovascular events and 13% risk in all-cause mortality. Not only that, it would reduce the risk of heart failure by 28%, stroke 27%, and coronary heart disease by 17%. But what if you are not able to reduce by 10, but say at least by 5? That also is beneficial. You'd be reducing major cardiovascular events by 10%, all-cause mortality by 5%, and heart failure, stroke, and coronary artery disease, respectively 13% and 8%. So always try to reduce the blood pressure and always try to achieve the goal. If you can achieve the goal, that's the best, but at times you might have to compromise, but then still you will have some beneficial effects. But we know most of patients are unable to, not most, I would say many patients are unable to reach the targets for hypertension control. And that's because of non-adherence. And a non-adherence could be because the patient is unwilling to do it. It could be because the physician's inertia, we didn't increase the blood pressure medication, or that the patients couldn't tolerate the medication. So all these are possible. But one thing we know, that the more number of pills that we give to the patient, the more is the non-compliance or non-adherence. So that's why the fixed dose combinations have been so popular. It reduces the pill burden. Now, the European Society of Hypertension and also the ESC now have said that RDN or renal denervation therapy should be the third pillar for control of hypertension. So the first pillar we know, it's your modification of the risk factors, the lifestyle. The second pillar we had so far, the drugs. And the third pillar is a procedure, which is an interventional procedure, that is renal nerve denervation. Now let's come to what is renal nerve denervation. As Dr. Kundu has already said, it's a simple approach. It's not something very complicated. It is an interventional approach where what we do is we actually ablate the nerves around the renal arteries. So both the afferent and the efferent nerves are actually damaged, are actually intentionally damaged or destroyed by either radiofrequency ablation, or sometimes this could be done by ultrasound as well. But today we are going to discuss more on renal nerve denervation with RF ablation, because that's where the evidence lies, most of the evidence, and it's been found to be effective. And this is not like, you can do a renal nerve intervention and then just come out. You don't leave a stent, there's no pacemaker, so you don't leave a device behind. And that's one of the beauties of this procedure. Now, how is this done? So you pass up a catheter into the renal artery. You locate the renal artery angiographically. You pass a catheter into the renal artery, and you then ablate. It's just using the radio frequency impulses, and you damage the nerves which surround the renal artery. And you do it not only the proximal part of the artery. It's seen, for the other studies have shown that if you have to do it the distal part of the artery as well, because our nerves surround the entire arterial tree, supplying blood to the kidney. Now, why and how is it effective? What's the mechanism behind it? Now, we knew for long that the actions of the kidney are controlled by renal efferent nerves, and these nerves come from the brain, and then there's the sympathetic nerves, which actually then go into the kidney, and they actually help in stimulation of RAS, renin-angiotensin system. They increase sodium retention, and they reduce renal blood flow, and this causes a vicious cycle, which again it helps to ultimately increase the blood pressure. But later it was found that it's not only the renal efferent arteries, there are renal afferent nerves, efferent nerves. There are also renal afferent nerves as well, which actually carry the signal from the kidneys to the brain, and it stimulates the brain to stimulate the renal nerves, the renal efferent nerves. So it's some sort of a circle. It's a loop that's operating. So when you put this renal RF ablation, you not only destroy the afferent nerves, but you also destroy the efferent nerves. And this combination goes a long way to prevent the brain acting on the kidney. And so this feedback, this entire loop is destroyed. So even if there is a problem with your kidney, where normally that would cause the stimulate the brain and ask them to stimulate the kidneys and cause release of RAS, here that's not going to happen. So this is the way the renals, the RDN operates. Now, which patients with hypertension are suitable for RDN? So do you give it to all patients? No. Of course, the patient has to have uncontrolled blood pressure. Usually we'll come to that, that's resistant hypertension. Or there could be some patients who are actually unable to tolerate the blood pressure tablets, and that's why they can't be on all full medications. Rarely there are patients also who are unwilling to take tablets. We do not get many patients here because the alternative is even more expensive. But of course, you will be getting some patients who are unable to or doesn't want to take tablets. And also some cases where the blood pressure cannot be optimally controlled, but we can't leave it there as well, because these patients are at elevated cardiovascular risk because either they have hypertension or maybe they have diabetes or stroke or atrial fibrillation. So we have to control the blood pressure better. But one note of caution, you should exclude patients who have secondary hypertension. These patients are not for renal denervation. There you have to control the secondary cause first. Secondly, those with white coat hypertension, they should be excluded as well, because you don't give renal denervation therapy in patients with white coat hypertension. And the third is, if there is significant renal impairment, So EGFR less than 40 is now a contraindication because in these studies, these patients were excluded. We do not know the effect that would happen if you go with RDN in patients with EGFR less than 40. So, of course, physician, we must remember, just like any intervention procedure, there should be a shared decision making. So, physician thinks this is good for the patient, but we just can't say, well, this is the only thing you have and you must go and have this done. So, this should be a shared decision making. Patients and the families, their opinion has to be taken. It has to be thoroughly discussed and counseled. Why we are suggesting RDN? So we are not suggesting RDN to everyone. We are only suggesting RDN to patients who have resistant hypertension. We are unable to control them with drugs, and this is increasing the patient's risk. And then, as you know, it's a simple procedure. It doesn't need to be repeated. Once you do the RDN, the effect would be there. Once you do the RDN, your number of drugs that you are needing may come down. So these are the advantages that you have to explain to the patient. Now, what do we have evidence? Yes, we have a lot of evidence, but I wouldn't go through them all details. It would be a little bit boring. But there are studies called spiral hypertension off medication and spiral hypertension on medication. Essentially, what it showed, the one off medication showed that in patients who are not getting any medications for hypertension, if you do an RDN, then we are going to still reduce the blood pressure to a significant degree. And spiral hypertension on medication trials showed that patients who are already on hypertension, if you are adding RDN, then also we are still causing a reduction of blood pressure. And the distal study actually showed that the renal nerves not only have to be destroyed in the proximal part, but also distal part of the renal arteries. So that's more of a technical thing. And there is Radiance Hypertension Solo study. This is one which used endovascular ultrasound to denervate the renal nerves. Now, it's been seen that in all these studies that your systolic blood pressure falls from the baseline. And if you look at the renal, either at the hypertension with on those who are on medication or those who are off medication, in all these patients, there's significant fall in blood pressure, irrespective of whether this patient is on medication or not. And interestingly, the advantage, all the medications, they do not act for 24 hours, but yes, RDN would act for 24 hours. So you really don't have to bother about what time of the day you are taking your medication. Now, it has been seen that it is effective in all different subgroups, like the diabetic patients, those with CKD, barring those who have severe CKD, in those with isolated systolic hypertension, in elderly, and also those with atrial fibrillation. So there's no subgroup as such which, where it is less effective. So there is a study, there's a registry called Global Simplicity Registry, which is going on and looking across those patients who had renal denervation done. And more than 3,000 patients have been observed for the last few years, and it is confirmed that it doesn't matter whether you're elderly or you're young, whether you have diabetes or chronic kidney disease, atrial fibrillation or sleep apnea, it's effective in all these cases. So now just one question. If you have a medical treatment that reduces the cardiovascular risk by 10%, which reduces the systolic blood pressure by 5 to 10, helps you to achieve the target, which is safe and which is effective and doesn't solely rely on medications and always have a persistent effect. So it's not that you have to take medicines every day. So why not would you prescribe RDN as a treatment? So this is the latest guideline from the ESC, the 2024 guidelines, which says about renal denervation. So if the patient is on resistant hypertension, and by definition we know they have to be on 3 blood pressure lowering medicine, including 1 diuretic, and still fails to achieve the goal, then they should be recommended RDN. Of course, it's a class 2B therapy so far because we need more evidence, but still it's something which you do not have many options at that stage, and it's something you should recommend. And also, And sometimes if the patient is at a very high risk of cardiovascular disease, then also you can recommend them even if there are less than 3 medications. But it should never be recommended as a first-line therapy yet. That's a class 3, that should not be done. And as I've already said, those patients who have a eGFR less than 40 or those who have a secondary cause for hypertension, these patients should be excluded. Now, so in summary, patients who have a blood pressure 150 or more despite taking medications, at least 3 medications, including 1 diuretic, they should be seriously considered for RDN therapy. You need to exclude white coat hypertension and secondary hypertension before you subject these patients for RDN therapy. And it's very important that you discuss the counsel the patient properly, tell him what's the risk and benefit. There's not many risks, but still you have to tell them before you actually, sorry. I think this was the last slide, yeah. Doesn't matter really. I'll just see. Yeah, so that has to be done before you go ahead with any therapy. Yes. So thank you very much for the talk. If there's any question, I'll be happy to take.
Why is it contraindicated below eGFR below 40?
The trials haven't actually looked at this because all the trials, because we are doing something in the renal artery. If the patient already has a compromised renal function and something happens, then that can cause problem. But maybe later when you have trials below that, maybe include. At this moment, no.
What do you mean by resistant hypertension?
Yeah, as I've said, by definition is when you are unable to control the blood pressure, that's unable to bring it to the target, despite the patient being on 3 medications, and one of them should be diuretic, and provided you have excluded other causes, like there could be pseudohypertension. For example, the patient is actually not taking the pills you have prescribed, or the patient is taking a lot of salt for which the blood pressure is going up, or the patient may be having secondary cause of hypertension. So once you exclude these reasons, then it's a true resistant hypertension. And if despite 3 medications, including 1 diuretic, you are unable to achieve the goal, then it is an indication. It's a resistant hypertension.
So, Professor Banerjee, do you think this therapy is more useful for young hypertensive because it cuts down symptomatic overactivity?
Yeah, absolutely. Young hypertensive, this is for one, its effect would be more likely to be more effective. Secondly, if you control the blood pressure at a comparatively younger age, then you are also avoiding the ill effects of prolonged rise in blood pressure. So that's why definitely.
What is the approximate cost of the
Sorry.
Is there any post-operative side effects?
Yeah,
We are touching the nerve.
Sure.
But nerves have some action.
Well, doing the nerves knot, initially it was thought like whether it can cause renal artery stenosis and whether it can cause renal damage. So these were the 2 things which were anticipated. But subsequently the trials and the registries have shown that these are not really of concern. Sorry.
Is it very costly?
Yeah, it is costly. How much is the cost now?
It depends. The MRP is around 7 lakh, 7.5 lakh.
So about 7-8 lakhs, yeah.
Malignant hypertension, what is the rule?
In malignant hypertension, first we actually have to reduce, control that. We do not straight away go for RDN. First, if you have malignant hypertension, we have to control with medications. And once that's controlled, then we can think like if the patient is still, the blood pressure doesn't come down to target, we can think about it. But for malignant hypertension, we wouldn't go ahead.
What is the science?
Sorry?
Real world evidence, any studies?
Yes, that's going, as I've said, there's a real world, that's a global registry that's going on. That's a much more enrolled more than 33,000 patients. They have shown there's a safety data is quite good. Sorry.
What is the sign and symptom for innervation therapy?
Yeah, this is a procedure. I mean, the signs, there may not be any signs and symptoms. So you do it like if you have resistant hypertension and the blood pressure fails to come down despite medications.
Is there intraoperative risks?
As I've said, one thing is there could be, because it's an intervention you are doing, there could be bleeding risk from the access site. And then if there is too much of energy that's given, then there is a possibility that it can cause renal artery damage, later leading to renal artery stenosis. But as I've said, if you have experience and the experience is not very steep, so you can actually get it very quickly, I wouldn't anticipate any problem from there.
Sir, is there any
Will
video?
there be any chance of renal necrosis due to decreased renal blood flow?
No, there is no renal decreased blood flow unless, say, while in many very inexperienced and who have never done an angioplasty, if they accidentally damage the renal arteries and all, then only such a situation will arise, as it happens in any surgery. But as such, risk is very low.
Is there any video? How it is done?
In your practice, number of medicine is reduced.
If you do a successful renal nerve denervation, then probably you may need less number of medications. But again, at times what may happen that is simply with some 4 medications or 5 medications happen, the blood pressure is not reduced to that target. So once you do the RDN, it achieves the target. So you may or may not be able to reduce your blood pressure.
So, if I get it right.
Sorry, you may not be able to reduce the number of tablets. Yeah.
So, if finance is not a problem, then before going to second line antihypertensive, you will like to try renal denervation. Is it so?
See, if you look at the indication now, it's 2B. Though it says like if it's not working with 3 drugs, you can go ahead. But still, I think I would go with it's 2B, whereas the other medications will be a bit higher than that.
What is the side effect of denervation therapy after that is passing through the artery?
No, this is not the side effects. That's why I said some side effects may common to everything, any access, like access sites bleeding. You go through the femoral artery and then you have some bleeding. That even happened with angioplasty. So that's one. Second, that's the only thing I think which is probably of some concern. But it's nothing more than what you would normally get with any
From the brain there is one nerve is coming and to the kidney. Is there any problem?
No, it's been seen like just ablating these nerves have no long-term effect, detrimental effect, I would say.
What's the age of this global registry?
This has been going on for 3 years, more than 3 years. Yeah.
The cases are followed.
Yeah.
So is
In
there
case
any
of
video?
No, sorry, I don't have any video with me. No.
So,
In case of resistant hypertension, what will be the time factor after giving antihypertensive that they will be selected for renal denervation?
See, I think it depends actually. They should be getting adequate time. But I mean, it's not that.
What I mentioned.
No, there's nothing like you have to wait for 3 months or 6 months. There's no mention of that.
Is there any incidence of recurrence or resurgence of hypertension?
See, this is something I went through, and they say like it is rare. So actually, but if you think about it, if a patient who has got it done, he stops all medication, he doesn't follow the lifestyle, then it's likely that the blood pressure may still go up, isn't it? So yeah, that's
Age selection?
as I've said, there is no age as such. It's effective even in the elderly, also in the young subjects.
So one thing is sometimes what happens, systolic pressure is 145, 150 like that. And if you increase the medicine, diastolic goes down and down and up to 60, 55. What to do in this?
That's a difficult situation, but I think especially what we know now in elderly subjects, the systolic is more important. We should try to bring the systolic to the level first, and then if the patient has a coronary artery disease and the diastolic is too low, then probably we shouldn't try to bring it down further. We may have to strike a compromise because we know that the diastolic pressure may be important in patients who have significant coronary artery disease.
That means normal is 120, 70, not 80.
Is it less? Yeah, it has to be less than 80. It says between 70 and 80 and 120 to 129. Say 120 to 130.
Is there any question? So from the audience?
So, is there any further questions from audience? If there is no, then I will invite next speaker, Dr. Sumanta Mukherjee.
For that, I request the chairperson to hand over a small memento to our speaker.